Session 4, System Transformation and the ACA. And starting us off is Eric Patashnik. Thank you, Eric.
Thank you. Thanks so much, and it's a treat to be here. Such interesting colleagues and panelists. Thank you, Colleen and Harold, for the invitation. What I want to talk about today is this new initiative in comparative effectiveness research, which is an important part of the Affordable Care Act. And I should say that this is a joint project with Alan Gerber of Yale, and our research is supported by an Investigators Award from the Robert Wood Johnson Foundation, as well as grants from the Smith Richardson Foundation. And some of the work that I'm going to be talking about is co-authored with Connor Dowling of University of Mississippi, as well as Dave Doherty, who's here at Loyola in Chicago. So the major problem that the Comparative Effectiveness Research Project is trying to address, as many of you know, is the surprisingly, even shockingly weak evidence base of American medicine. We have one of the most sophisticated healthcare systems in the world. Tremendous technological ingenuity goes into our treatments. An incredible amount of research and development in new products. And yet, despite that investment, we know that many treatment options have never been rigorously tested to see if they work better than alternatives. There may be a particular condition, and it can be treated through multiple options, various pharmaceuticals, devices, surgeries. We may not know what product works best. And in addition, despite the fact that we have the FDA, which looks primarily at pharmaceuticals and devices, many medical studies are focusing and giving us information that is arguably not addressing the question we most want to answer, which is how do we make people well? A lot of times what the studies are telling us is whether a particular product performs better than a placebo on a surrogate measure, such as a lab test, rather than the ultimate clinical outcome that we care about. There's a lot of discussion about just how bad the problem is, but some estimates suggest that less than half of all the medical care that people receive in the United States is supported by adequate medical evidence. And this is, I think, a really shocking issue for all of our distributional and equity concerns that we have in healthcare. There's also the issue that even well-insured, affluent people who think that they have the best possible insurance may, at times, they and their loved ones, be getting treatments that may not be the most effective for their condition. And in many cases, the reason is we simply don't know what works best. And the consequences of this problem are vast. It lowers quality, it raises costs, and increases patients' risk without offsetting health benefits. There have been times, multiple times in the United States, where quite risky medical interventions, high-dose chemotherapy plus bone marrow transplant for breast cancer, for example, would diffuse into widespread use without rigorous evidence that it works better than safer alternatives. And only later did we find out, after many people are harmed, that actually those increased risks did not produce the desired clinical outcomes. So this is a very, very serious healthcare problem in the United States. The Obama administration, I think to its great credit, recognized this problem. And in beginning in the 2009 stimulus bill, started investing money to try to improve the medical evidence base. And that effort was continued in the ACA, the Affordable Care Act, with the creation of the Patient-Centered Outcomes Research Institute, or PCORI, to set research priorities, and it's funded by Medicare and a tax on private insurance firms. Now, I've given this presentation a couple of times, and in this slide, a few times I've gotten the question, so what was it like to brief President Obama? And of course, that is not me. That is former OMB Director Peter Orszag. I don't know how we could be confused. He's a foot taller and nowhere near as cute. So, some people have great hope that the CER initiative will ultimately transform the American healthcare system, will help us identify unnecessary treatments and help us figure out what works best for different patients, improving both quality and reducing costs. Now, We don't know, however, whether this initiative is going to work. It's only in its beginning stages of implementation. Will it actually transform the healthcare system? Will it even endure politically or fall apart like many previous efforts along these lines have in the past? Indeed, CER has a very checkered history in the U.S. Efforts in the past to establish agencies to improve the medical evidence base, when they've come out with studies that have suggested that common treatments might not work so well, inevitably it's generated backlash from providers and patients groups that have been concerned about treatments that they want being denied coverage. And they've collapsed under political pressure. So it's very much an open question whether this entire effort will last. What we saw, of course, was this was originally a technocratic effort that had bipartisan support among healthcare experts. Certainly the Peter Orszag's of the world, but also the Gail Walensky's of the world, who headed up the Medicare agency under the first George Bush and was an advisor to John McCain in his campaign. But during the debate over the stimulus bill, as well as during the debate over the Affordable Care Act, the CER initiative morphed into a highly politicized symbol of rationing. And it got caught up in the debate about end-of-life counseling and the Medicare board, all creating a specter of death panels and interference with the doctor-patient relationship. So we saw this happen. It began with, as part of the effort to discredit the Affordable Care Act, arguments made that this is going to be used to ration care. And the result was that PCORI was funded, but the actual language of the ACA includes a lot of restrictions on how the information can be used. PCORI cannot mandate coverage or reimbursement or other policies. We're not going to be able to see the kind of use of qualities that we've seen used in some European countries as a measure of cost effectiveness. So very much an open question where this initiative will be, what its long-term impact will obtain. What we do in this study is trying to understand the politics of this issue, and part of what we're doing is looking at public opinion surrounding these questions. We're interested in a variety of issues: beliefs about medicine, how effective do people think modern medicine is, do people think today that medicine is evidence-based, what are people's policy preferences on CER, what kinds of policies are people willing to support, what do they most worry about, and the political debate over CER. How politicized is it? How does exposure to the different kinds of arguments that people make move public opinion in what direction? And then, if we are thinking from a sort of advocacy standpoint, what kinds of approaches are most effective in building public support for this important initiative? We're also looking about beliefs about doctors and how to build support for CER and what strategies would be most efficacious. So the findings I'm going to be talking about today come from 4 internet-based surveys. This is increasingly a common method used in political science, carried out through YouGov. These samples are nationally representative. Most of them are ends between 1,000 and 2,000, and they are representative of the U.S. in a range of demographic characteristics, including health status and health insurance status. So just as a baseline, I think it's very important to remember how a lot of Americans think about healthcare. First of all, Americans start from the assumption that recent innovations are, in general, more effective than previous treatments. So there's a kind of bias for newer is better. 8 in 10 Americans believe that. Remarkably, 56% of Americans in our sample agreed with the statement that modern medicine can cure almost any illness with advanced technology and treatment. There's also, as political scientists are increasingly finding in a range of domains, a kind of belief system that many experts would find not credible, but a belief that somehow there are all these cures and the system is somehow rigged, and it's big bad drug companies who are trying to protect their profits. And we found, for example, that 68% of Americans agreed with the statement, drug companies keep cures for some serious medical condition secret to protect profits from current products. That just gives you a little bit of the kind of way that ordinary Americans think. We also were interested in trying to, as a baseline, understand, do ordinary Americans think that the U.S. healthcare system spends a lot more than European countries and maybe doesn't do dramatically better? And so we asked Americans about that, and we found that the vast majority of people are not in the intersection of the cell that thinks America both spends more and does no better than in European countries. That's a minority of all Americans. So if you start from that baseline of beliefs, you can see where people might become very fearful about change to the U.S. healthcare system. We asked Americans, do you think that your health care is backed by strong evidence of effectiveness? And then what about the care received by others? We found that there was a little bit of some difference here, but 60% of men said that of their own care, more than half is backed by evidence, and they thought that the care received by other people, 53%. Women were a little bit less optimistic. They said 41% of women said that they thought that half of their own care was backed by evidence, and that only 34% received care by others. And this, the gender difference holds up when you control for everything else. It's a pretty interesting thing that we have not fully investigated. You know, what explains this gender gap in perceptions of the evidence basis of medicine? We can talk more about that. Yes, that could be it. Importantly, from a political science standpoint, there is a significant partisan divide. We asked people, are you willing to, this is our baseline question, are you okay with just allowing taxpayer money to pay for studies? Nothing about how the information is going to be used, but just can we do some more research to improve the medical evidence base? On a 1 to 100 scale, the mean was 62, but what's important to see is that there's a partisan difference, and it's not in the whole electorate. It's rather among the more attentive voters. It's among the people that were picking up, in other words, that among political elites, this issue became highly politicized. And so you get a very big difference where among voters, Democrats are much more supportive of spending taxpayer money on these studies than independents, who are in turn more supportive than Republicans. And again, that's only among voters, not among the population at large. These are the people that pay more attention to politics. I'm going to skip that. So another issue we were interested in is trying to understand, well, what policy options are acceptable or unacceptable to the public? And so we asked our samples to evaluate how they felt about a range of possible uses of evidence. And what we found in general was Americans are consumers. They want information. So if we tell people, we're going to just give you better information, there's tremendous support. Overwhelmingly, people like the idea, very supportive of providing information about whether a given treatment works better than alternative ways of treating patients with the same condition, or even creating warning labels for treatments that are not supported by strong evidence. As you begin to have more bite in ways that would more directly control the cost of medicine, use this information to try to weed out expensive but ineffective procedures, the more resistance you begin to see. So, for example, at the bottom of the screen, there is overwhelming opposition to proposal to charge a patient more to get a treatment that research has shown has not shown to be effective, even if the patient's own doctor recommends it. So if we say, okay, let's say there's a study that says this doesn't work very well, you can still have it, but we're just going to make you pay a little bit more. But are you comfortable with that if your doctor says you should have it? And there's no support really at all for that proposal. What about the idea of establishing a board? This is not the board we actually have, but a stronger board that would have the power to mandate guidelines that doctors would be required to follow, evidence-based guidelines on how to practice medicine. Overwhelmingly, people oppose that across the political spectrum. Republicans more than Democrats, but nobody supports the idea of a board that would have the ability to mandate how doctors practice medicine. We did look at other ways to try to think about how could you link the evidence base to healthcare cost control. One thing we saw was, to go back to the carrots and sticks, people do like the carrots a lot better than sticks. So if we said, we will make you pay a higher copay to get a more expensive treatment that research shows does not work better than a cheaper alternative, people do not like that. But what if we flipped it and said, how about being an insurance plan where you can get cash back if you agree to get your treatments from a formulary that's evidence-based? People were more enthusiastic about that idea. Okay. Another idea, again, is this idea of treatment guidelines to try to deal with the vast that we know of geographical variation in healthcare, maybe to try to standardize best practices. That's one argument for trying to have more guidelines-based care. We did another survey where we gave people the arguments for it and against it. And what we saw was there was some agreement with the main reasons why you might want to have these kinds of guidelines. For example, I know this is small type, example, doctors are affected by economic incentives, and that can lead doctors to give patients unnecessary care, or that requiring doctors to follow evidence-based guidelines will improve care for most patients, or even that doctors in a given area may be unaware that a better treatment approach is being used elsewhere in the country. That's the top, and you could see there's some support for that. But the arguments against were resonated much more strongly, and the red is people who thought it was either very or somewhat convincing, but the blue were people who thought it was very convincing. And what we saw among the public is people were much more likely to find the arguments against the use of these guidelines very convincing. And really, I mean, majorities in many times were saying this is not only convincing but very convincing to me. For example, no outside group should come between doctors and patients in making treatment decisions, that doctors are going to be unable to tailor care to the needs of individual patients, that the government insurance companies are just going to use treatment guidelines to control costs and ration care, or that it's going to slow medical innovation. Here we looked at the debate over CER. I mentioned that we saw a baseline. There was a willingness of the public to pay to have these studies done. We said, well, what if we expose people to politics? So we did a survey experiment where we gave them the kind of arguments that you see in the political sphere, both the pro and con. And for the pro arguments, how this information is going to improve healthcare outcomes for patients, or how it could help reduce the budget deficit by cutting wasteful medical spending without lowering the quality of care. And the anti-arguments were, this is only going to lead to cookie-cutter, one-size-fits-all medicine or ration care. And what we saw was if you give people both the pro and the con arguments, it's just the con is pushing people down. That's why these all the cells are negative. People are just finding the negative arguments more persuasive. We followed up, and we said, well, let's try to, can we overcome that at all? We did another survey experiment where, and I won't be able to show you all of them here, where we were trying to find a way, can we counter this in any way? And so here's an example where that one-size-fits-all argument, this is going to be, somehow the government insurers are going to come up with some protocol, and they're going to say everybody who has this condition has to get it, and that's just not tailored enough for me. It's a very powerful argument for people. And we looked at, well, how could we specifically rebut that? And we gave a bunch of possibilities, and really the only argument, and this leads into where I'm going to go for the rest of my presentation, that really moves people is doctors. If we tell people, doctors want these studies, doctors think these studies are a good thing, that's what people find persuasive. All the specific arguments, the substantive arguments, are not as persuasive to people as, I trust doctors. If doctors say we need these studies, that's what I want to hear. And that really is the main conclusion I want to make, is that in the healthcare sector around what treatments people get, there are a variety of players. There's government, there's insurers, there's drug companies, but there's only one set of actors that the public trusts, and that's doctors. There's been an erosion in their public authority over the last 30 or 40 years. That may be true, but relative to all the other players, doctors stand very tall, and they are trusted by people. Here's another example. Majority of Americans agree that if a treatment only helps some patients who get it, your doctor knows whether you will be among those for whom the treatment is effective. It's good reason to think that's often not true, actually. Doctors actually often can't tell ex ante if, say, a treatment helps 1/3 of the people, whether you're going to be among the 1/3, but people do tend to think your doctor can figure that out for you. What we did was trying to open up the black box a little bit and understand how people see doctors. And so we asked people to think about how they compare doctors to various other kinds of actors in our society, lawyers, teachers, members of Congress. And what we saw was, unsurprisingly, members of Congress didn't do so well, but even among, compared to elementary school teachers, when it came to things like empathy, do you think your doctor really cares about people like you? People rate their doctors very, very highly, and it's really quite remarkable. Now, you might say, well, people love their own individual doctor, but they realize that medicine is a big business, and they realize that these medical societies they're kind of trade associations who are kind of protecting their own interests. Well, many of us experts sort of think that way about what doctors' associations do, but not the public. Actually, the public thinks about organized medicine not so differently as they think about their ordinary, their individual physician. And they really think that the motivation of medical societies is in many ways much better than other business organizations or unions or health insurers on a variety of kind of questions. We really see that people, even though we have seen repeatedly doctors, when they organize collectively and they're involved in public policy decisions, involved in pushing for higher Medicare funding, their behavior is not dramatically different than any other interest group in the arena, but people do not see medical societies as just another interest group. They really see even organized medicine as motivated to do what is best for patients. So here's a survey experiment we were doing to try to understand about building public support for a proposal to reduce healthcare costs. Obviously, healthcare costs is a big issue in the United States. And in this survey experiment, we had a variety of conditions. We assigned one of three physician Q conditions. The first one was no Q from the AMA, and we use the AMA as simply a stand-in for a medical group that would be familiar to the public. One was we told people this generic proposal, which had no content. We just said, this is a proposal to reduce healthcare costs, and we said, in this arm, the AMA is for it. In another arm of the experiment, we said the AMA is against it. And then we had five partisan Q conditions. One was no political endorsement. One, we told people this is supported by congressional Democrats and opposed by Republicans. One supported by Republicans and opposed by Democrats. One supported by Democrats and Republicans. And one supported by a bipartisan commission on deficit reduction. And so we asked the people in this experiment, if you knew that these people were for or against this generic proposal, would that make you more or less likely to support this generic proposal? And what you see is the most important thing that we found was it's the doctors are the only group that moves the public. The net difference between AMA support and opposition was statistically significant at 0.001, a 0.41. What we found surprising was there was absolutely no impact of the bipartisan commission. So if you tell the public a bipartisan commission thinks this is a good idea, it does absolutely nothing, at least in this healthcare area. Now, what I'm not showing you here, of course, is the partisan cues work. If you're a Democratic voter and you hear the Democrats are for it and the Republicans against, you're more for it, and vice versa if you're Republican. But of course, we have a pretty divided country, and so those things are pretty offsetting. If you're trying to move the public as a whole, the only thing we found was doctors. In another experiment, we looked more specifically at using comparative effectiveness research as a tool of cost control. In this experiment, the proposal was having government or insurers refuse to pay for treatments that are not supported by evidence. That was the proposal. If something isn't backed by evidence, we're not going to pay for it. Didn't say you couldn't pay for it yourself, just said it's not going to be paid for you unless it's evidence-based. And we gave a variety of cues to see what would move people. What we found was, again, if we tell people leading doctors support this, that boosts support for the proposal significantly. Interestingly, if we tell people patient advocacy groups support it, it had no effect. And if we tell people that top drug companies and high-level government administrators, support So what are some preliminary conclusions here? First of all, what we see in the public is support for evidence-based medicine through investment in comparative effectiveness research is conditional. The public does support the idea of improving the evidence base. So anyone who's arguing there's no support for this, that's false. The public does want the studies. The public absolutely wants more information. We are nothing but good shoppers in the U.S. We would like to know more what works. However, the support is conditional on how the information is used and evidence is integrated into practice. The more people see it as something that is going to be used to try to control the costs of care or influence how their doctors behave, interfere with their personal relationship with their physicians, the less they like it. Policy design matters. The public is willing to consider the use of financial incentives to encourage patients to use cheaper but effective care, but they like carrots better than sticks. And most importantly, what we see is elite cues matter. This is an area where this is a very highly technical area. The public is looking for guidance. The public wants to be told what is the right policy, and the only group of actors that the public trusts when it comes to health care is doctors. Thank you.